Hi, Dave Lockwood here again with Percussionaire Corporation. As I mentioned in our first video, we have received a lot of inquiries from hospitals throughout the United States and Europe wanting to know if our IPV therapy or our VDR ventilator was effective with COVID-19 patients. As I mentioned in the first video, yes, they have been very effective. And I bring you another one of our one-on-one interviews with experienced advanced clinicians from around the United States and Europe who have been using our products with COVID-19 patients. And once again, they will talk about how they've been using them. I hope you will find this series to be helpful with the use of our products in your hospital. Thank you. Today's interview is with Craig Ivey. Craig, can you tell us a little bit about yourself?
Hey, thank you. As you said, my name is Craig Ivey. I am the Enterprise Director for Respiratory Care Services, Santa Clara Valley Health System. Encompasses about 1,100 beds in the Bay Area, the Silicon Valley, San Jose area. I've been a therapist for 33 years, 29 of them here at Santa Clara Valley. So a lot of experience there, a lot of time. It's a 700 bed teaching facility affiliated with Stanford Medical Center. A lot of the specialty care areas, the level 3 nursery, level 1 trauma, spinal cord injury, things like that.
So it sounds like you get quite a bit of experience and quite a bit of variety of patients you see.
Yeah, and actually that's what I really enjoyed about it when I first started working there. I was, believe it or not, I was really, really, really young. I was about 18 when I started. And to me at the time, it was all that excitement. I could work in all these different areas, see the different types of disease processes and the different age ranges, and go to the trauma center or go to the trauma calls. So it was the variety that drew me. It was the patients kind of kept me. We see a lot of medically indigent patients, not to mention, those patients, but, the kids in the NICU, the pediatrics, the burn patients, those young patients that get spinal cord injuries, or all patients that get spinal cord injuries, and learning how to not only treat them, but deal with them as people. It's, like I said, it was the variety that brought me. It was the patients that kept me.
Excellent. So I know you have both IPV therapy devices and the VDR that you've been using for quite a while. And I understand you've been using both of them with COVID-19 patients. Is that correct?
Correct. We've been doing, we actually started IPV back in 1996. We started using, brought it in for our burn unit. But it's grown tremendously since then. We do it in line with our ventilators. We do it for non-intubated patients as well, but we do it in frequencies from continuous IPV therapy up to, BID or something for a spinal cord patient. So yes, we use it. We use IPV, and then we started VDR4 in about 2004. The VDR4 has been a little bit. It's been much slower to take on as far as continual frequent usage with some of our physicians. But when we use it, we have very good success with it.
Excellent. So with COVID patients, what point did you start using the VDR early on, or did you start using it more as what a lot of people do as a salvage or rescue ventilator? And what were your experiences using it?
Actually, we weren't using either IPV or the VDR on COVID patients when it first came out. When the CDC came out with the recommendations on aerosol generating procedures, we said, all right, we're not going to do anything like that. We're not going to do nebulizers, and we're not going to do IPV. We're not going to do VDR because the flow that it generates, the leak that we keep around the cuff, we didn't offer it. That lasted about 2 weeks. And then we had a patient that was not doing well at all. Excuse me. We started them on continuous IPV. because at that point, the physicians weren't ready to go to the VDR. This patient was on continuous IPV for a couple of weeks and ended up getting extubated. And so our use of IPV and then eventually the VDR just kind of snowballed from there. I think it was probably 2 or 3 weeks later, we put our first VDR patient on. And since that time, we've gone, we still do IPV, but now our first line of choice is the VDR. So we're using the VDR a lot more and a lot more frequently now on all of our COVID patients, our ventilated COVID patients.
So that's interesting, because that is a lot of the questions Percussionaire has gotten initially is how can you use IPV therapy or the VDR with potentially aerosolization of oral or lung secretions. So how did you deal with it?
As we told the staff, our hospital, as most hospitals do or should, or all hospitals should, is we provide the appropriate PPE. And our comment is, if you're protected, then we're not as concerned. I mean, we're in isolation rooms with negative pressure. So we're doing all of the things necessary to protect the employee and to protect the other employees in the unit. We're keeping the doors closed. We're vacating the air. So we're staying safe. And as long as you're staying protected and safe, then doing IPV or using the VDR isn't as big of a concern. Now we're doing what we feel we need to do is best for the patient. And we felt IPV and the VDR was what's best for the patient. You asked earlier about, how did we use it? Was it a rescue or was it earlier? And we started as rescue. Like I said, we've been using this since 2004, and probably 80–90% of those cases have been rescue. And trying to instruct the physicians or trying to teach the physicians that earlier application may have better results. Well, with COVID, it was rescue. And it took a couple of very strong-willed staff members to continue pushing the physicians. Well, now it's not rescue. Now it's early application. And the successes that we expected to see, we're now seeing. We're not waiting until the patients are circling the drain. And yes, we may change or affect blood gases. We may prolong life for a couple of days. But in the end, a lot of these patients were still expiring. They were still dying. And then we started earlier application. And funny thing, all of those early application patients have survived.
That's exactly what one of my other interviews, the same results. And now they're starting it with COVID patients. If they get intubated, they're automatically putting them on a VDR. And the physicians are now wondering, on other non-COVID patients, ARDS, pneumonias, maybe they need to start earlier rather than waiting till it has to be rescued. I kind of look at that as I sail a lot. If a person falls overboard, we're turning around and saving that person immediately. And I think in the medical field, we should do the same thing. We kind of wait in the medical field. My personal opinion is we say, let's not rescue that man overboard until he's underwater, which does not make sense to me.
It doesn't make sense to me. And I've had these discussions with our medical director several times. And for us, not for us here, but what it appears and how it's explained to me is that, one of the, if there's an issue with the VDRs, there's just not a lot of, randomized studies on the use of VDR and ARDS, non-inhalation injury, things like that. So, or the community standard isn't the VDR. So we get that a lot. And we're in an area with Stanford Medical Center, with, UCSF, San Francisco General, Oakland Kids, and they're saying, well, if the community hospitals aren't using it, why should we be using it? It's not the community standard. So we get a lot of that. But with the success that we've had over the last several months, it is having those pulmonologists ask those questions. Well, we need to look at doing this with our other patients a little bit sooner. Or we now have pulmonologists come in and saying, we've looked for literature, we're not finding exactly what we want. Maybe we should do our own now. So the interest on our pulmonologist part has grown exponentially, and that's huge for us. That's what we've needed all along, is our pulmonologists to see the success that we can have. And it's not that we haven't had success. During H1N1, we had tremendous success with the VDR. But when H1N1, went away, the use of the VDR wasn't as much. Well, now another situation has come up. The COVID situation has come up. Our VDR usage has gone way up. The difference is this time we've got the physicians talking to the therapist, asking the therapist, well, is this a good time for the VDR? Or what do you think about this patient? And then the therapists or the physicians are that sounds bad, that they're invested, but they're always invested in their patients, but they're now getting invested in the VDR. And that's the difference, because they are seeing the success that we've always felt that the VDR could provide.
It's been interesting with the COVID pandemic. It's horrible. You don't wish it upon anybody, but it is actually sheds a lot of light on how effective the VDR has been. We have Los Alamos National Laboratories actually has been studying the technology of high frequency percussive ventilation, and want to study it deeper because they feel there's a lot more applications for it with the pulmonary physiology and disease states. With your use of the VDR, have you seen you're using it significantly different than you would use it on another patient? Are you using higher frequencies, lower frequencies? What are you seeing?
I think, like a lot of hospitals, a lot of departments, the way we've treated these COVID patients have evolved. They've changed since March of last year or February of last year. We have changed the way we do some things, but we realize every patient's different. And so it may be that we put one patient on and it's just like we've always used it. And then we have the patient right next door that needs a high frequency rate of 700. Well, then we'll put them on a pulse frequency of 700. So we have changed the way we do things. More importantly, we've changed our options, I guess, to put it that way. We don't rule anything out. If we need to go on a higher percussive rate or a lower percussive rate, we do that. If we need to add a little bit more demand PEEP or a little less demand PEEP, or start no demand PEEP, we do that. If we need, convective pressurize on or not on, it just all depends on the patient. And now, again, with the physicians on board and the therapists more involved, we don't rule anything out as far as what we need to do for the patient. And so to answer your question, no, we've changed the way we do things, but there is no standard way we do things. We have some guidelines. Here's where we're going to start our convective rate. We're going to start our pulse frequency at 500, but doesn't mean it's going to stay there. So before we were, I'm not saying rigid, but our convective rate would stay at 15. Our high frequency rate would stay at 500, and we would just adjust pressures. Well, now we're not doing just that. If there's something else that's going to help the patient, then that's what we do.
Very good. Very good. And you've also been using Ipv therapy. Have you been using that strictly interfaced into your conventional ventilators, or have you used it on non-intubated patients, maybe patients who are on, say, high flow nasal cannula?
Actually, it's all been in line with our ventilators. That's probably, and we do a tremendous amount of IPV, and probably 80% of it, 85% of it is done in line with a ventilator. We don't do as much non-invasive or non-intubated patients. It's an area that we need to grow. It's just not something that we've done, again, because probably 75% of our patient workload is ICU. So that's where most of the need is.
Okay. I heard about one particular, I think, patient you had where you essentially put your IPV in line and ran it continuously, kind of mimicking VDR ventilator with your
Yes.
conventional one. Is that correct?
Yes, we do that frequently. And I know people that see this will say, well, why don't you just put them on the VDR? And we don't disagree. It was getting the physicians to order that VDR for us. So the therapists would do and use the tools that were available to them. IPV's always been available to us, and it's always been available in line. We do it continuously. When we couldn't get a VDR ordered on a patient, we've run it IPV in line for 3 or 4 weeks continuously on a patient. We've had tremendous success at it. And again, use the tools that are available to us. Would we prefer to go to the VDR? Absolutely. But when that's not available, we use what we have.
I think that's smart, and it's all about helping the patient, and it sounds like you've been very successful with that, with physicians wanting to or seeing the rationale of going to the VDR. So I think that's very smart on your part. I know of other facilities where they haven't had VDRs, so they've had IPV, and they've done similar because of the lack of the VDR ventilator. So
yes. It's an effective tool, and if that is the best option that you have, you should use it. And I don't think we should limit ourselves. Well, IPV, it's only done intermittently. Well, who's to say it's only done intermittently? Does your patient need it more frequently? We try to teach the staff to be more aggressive up front. I'd rather be doing continuous IPV for 24 to 48 hours and then drop them back to Q4 or Q6, and we treat them for 4 days, or start them out at Q6 and have to treat them for 2 weeks because we just aren't having the impact that we should. So we try to be more aggressive up front.
Yeah, no, I think that's great. And when I do teach use of IPV, I tell clinicians if they're not intubated, you should do a 15 to 20 minute treatment. A 5 to 10 minute treatment is barely starting to loosen up secretions.
Yep.
And one of the facilities we had in Florida, they had a gentleman on a conventional ventilator completely white out of left lung. And so they chose to give him an hour-long IPV treatment interface to the ventilator, and just 1 hour later, the chest X-ray, the left lung was open. So point well taken.
It's stories like that, Dave, that I love to hear. Like I said, we've been doing IPV and inline IPV since 1996. Our first patient was on a burn patient inline in isolation. Of course, this was back in the 7,200 days, and there were some issues on how that interfaces. It wasn't the IPV's fault, but a long story. Anyway, so we've been doing it for a long time. An education coordinator that I work with, we went to a neighboring city and did a lecture, just a lecture on pediatric ventilation. But after that, they said, we've got this patient. They've got this huge white mass up in the left upper lobe. We can't get the patient off the ventilator. We've been on for this long. What do you guys think? Well, yeah, let's try IPV. And this was about 3 or 4 o'clock in the afternoon. By the time we got home, and it was about a 2-hour drive, the clinical specialist from that hospital had sent me a picture of the first ET tube that they had to actually urgently withdraw because it had occluded, because all of the stuff that it was getting out, and it was just this ugly, gunky stuff. They had to replace 2 ET tubes within 24 hours because of the stuff that was coming out. Long story, the good news is within 24 hours after that, the patient was off the ventilator. So for those that don't believe in it, it doesn't work, it's too much time, it's very labor intensive, but that's all true. But you have that one success that patient that you just see, you know, whether it's an asthmatic or, you know, COPD, whatever the situation is, you know, you have that one patient that just makes you open your eyes and say, wow, this is an effective tool.
So with that, coming to the end of this interview, Craig, would you say only use VDR as a rescue or salvage, or would you, in your opinion, see that maybe we should use it more often and sooner, and possibly right from the moment of intubation?
Yeah, I would actually say there are times where we should use it when we intubate a patient. You know, don't be afraid to use that tool in your toolbox. I mean, it's available. You have it available for a reason. It's not there to collect dust in the equipment room. Use it. It has these great effects on patient outcomes, anecdotally, that we've seen. And I think that if you use it effectively, you use it early, I think hospitals are going to have success. So the earlier, the better.
I agree. Thank you. Thank you very much for the interview, Craig. Much appreciated.